Thank you so much. So, as you know, we are recording this event, and we will get started because I do not want to waste your time today. But I think I actually had a couple of people on my last webinar about an hour ago. So, you know, and Marissa already knows that I will most definitely ask you to put your name in the chat, introduce yourself, because again, I will be your facilitator for today, but all my experts are in this audience right now. And what we learned from this last webinar, where I had this brilliant participant who just started sharing all these words of wisdom and all these gems. We really want to be able to pull that out. So I'm looking at people right now. I see Marissa and I see Mr. Randy. Hello. So I'm so excited for you all to be here. But we will move forward with our presentation for today. So just a little bit of housekeeping rules. Just keep yourself on mute to limit any background noise, and please use the chat to ask questions during the session. Now, I will be the first to admit that I struggle sometimes with the chat and asking questions and everything. So if it's something pressing, please just raise your hand and we can just open this up for group conversation. And as a reminder, the webinar will be recorded. And at the end of the webinar, we do love your feedback because that helps us improve. So please fill it out. So stay to the end if you can. So any Zoom logistics that you might have, if you need the captions or if you don't want the captions, please go to the bottom of the Zoom window and then hit a click live transcript button. And then you can either hit hide subtitle or show subtitles. And if you have any questions, please make sure you put them in the Q&A or the chat box, especially if we have any technical issues. And again, we are being recorded. So just a little bit about CSH. So we empower communities to to create homes and deliver services that build safe, thriving, and resilient futures. And we support affordable housing developers, service providers, and policymakers with the tools, data, and expertise to drive lasting change. And we have been doing this since 1991. And we have invested over 2.2 billion in communities that have helped create or preserve more than 500,000 supportive housing units for individuals and families exiting long-term homelessness. All right. Let's go, because now as you can see my computer. All right, and then we are also one of 22 NTAPs. And the goal of the NTAP is to make sure that we are supporting health centers, leverage all of your experience, and use the data that you collect to create high quality, comprehensive programming. So this webinar is being supported by HRSA, the Health Resources and Service Administration, which is of the U.S. Department of Health and Human Services, HHS, as part of an award to Corporation for Supportive Housing totaling $550,000 with 0% finance or non-governmental sources. And the contents are those of the author and do not necessarily represent the official views of or, nor an endorsement by HRSA, HHS, or the U.S. government. And if you have any more information, please go to the HRSA website. And my name is Becky Moses, and I will be your facilitator today. So I am one of the senior program managers at CSH, and I am based in Biloxi and New Orleans. Thank you, Marissa. Now, if you have any reason to get in contact with me, and again, I love for you all to get in contact with me because when we have future webinars, your voices matter. So as you can see, you can probably tell that Marissa and I have worked together before, right? And her voice has been very key in helping shape some of the materials that we put out there. So please stay in contact and let us know, how do we do? How can we improve and how can we tailor it for your respective communities? So just so we know about our learning objectives. So by the end of this session, you all will be able to understand the role community partnerships play in addressing non-medical factors of care, including housing-related barriers to care. And we are also going to be able to identify opportunities to engage community-based programs and service organizations. We are going to learn effective practices for building and maintaining cross-sector partnerships, even within your own agency. And we're going to use a case study, one of the agencies that I used to do a lot of referrals to. We are going to look at DePaul Community Health Center's Health, Housing, and Community H3C model as a case example. And we are going to apply lessons learned to strengthen care coordination and resource connection necessary to improve patient health outcomes. So I will be the first one to stress, you are going to hear things that you have already heard. So that's why you need to be in that chat, letting us know your bits and pieces of what it looks like in your community, because that is where the knowledge sharing happens. And that's what really drives the change. And it really helps with the community partnerships. So I really encourage you to use that chat and, raise your hand. So this is a good time because I'm going to call on people, right? So we want to know, what is your biggest challenge in connecting patients to community resources? And I'm going to look at the chat for a second. I'm going to give you all an opportunity just to think about it. Again, you can raise your hand or you can put it in the chat and I'll read a couple out. Okay, so I have somebody from Mobile, Alabama. Okay, awareness. Okay. Mr. Randy, would you like to elaborate on that?
Just them not knowing about the resources that they're eligible for. Pretty much, that's a challenge. It's not really a challenge with connecting them, but it's a challenge of them not knowing and not being aware of it.
Thank you for that. And Mr. Randy, where community are you from?
I'm from Morris Heights Health Center in the Bronx.
Okay. Oh, wow. Okay. So that's great to know because I think, you hear New York and you're like, oh, they know all the resources. And I used to live in Philly and I had all my clients tell me, I know the resources. So to hear that, like, kind of contradicts what we normally hear. Like, no, some people need to know what is available in community. Love that. And then I see Miss Laura, would you like to talk about following up on outreach to engage the client?
Sure. I'm from Long Island, New York, and I work at Options for Community Living. We help clients, who have mental health or substance use or chronic conditions get connected with their providers and housing and resources and navigating, social services, everything like that. Um, but I think a lot of it is, we'll either receive a referral for a client, and, depending upon the client's, technology situation or housing situation, sometimes it's tough to get in touch with them. So I feel like, kind of just trying to catch the client initially is, I feel like, the biggest hurdle. And then once you have them, it's so much, at least they know you, you know them. You can kind of get that and, get the ball rolling. But I think just that initial outreach and then just keep trying to reach them. And then maybe they're in the shelter system and they're not living where, their referrer agency thought they were living. So I feel like that's maybe the at least first hurdle that seems to be a little bit tough.
Thank you for so much for sharing that. I heard that in actually the last webinar that that's one of our challenges as well. Tavin, would you like to elaborate as well?
Sure. I was thinking in the climate we live in, lots of communities they go through changes and their circumstances will change. So being able to stay right behind them and making sure we're addressing the community need, the current community needs that they have and not falling behind because of course we want to give them the help right when they're facing that struggle. And of course, keeping up with them, making sure they're receiving what they need. I think that's the biggest challenge because of the circumstances constantly changing.
Thank you so much for that. That is accurate. Miss Anita, would you like to talk a little bit about transportation in your area and what area you're in?
Hello, I'm in Fort Pierce, South Dakota, so we are quite rural. And in town here, actually, the only transportation is a transit service, which of course there is a charge for that. For patients on Medicaid, there is a provision they can use their Medicaid to get to their doctor's appointments, but these people need food and other resources, so many of them do not have vehicles and certainly don't have the funds to get to the places they need to be.
Thank you so much for sharing that. That is absolutely accurate. I live in Biloxi, so I understand that one. And Marissa, would you like to talk about keeping clients and patients engaged?
Hello, everybody. My name is Marissa. I am from DEP Health in Palm Springs, California. Keeping clients and patients engaged, I feel like they lose a lot of hope when we tend to provide all these resources. But specifically for me, I am in the housing department, and I did a program for rapid rehousing, and they lose hope once they're offered that program. And they tend to be like, oh, it's too good to be true. Like, it's like playing the lottery, it's never gonna come, kind of thing. And just me trying to keep them engaged by saying, just keep checking in, and they disappear for a period of time.
Thank you so much, Marissa. So as we can hear, like we have people all throughout the United States on this call. We have people from Texas, we have people from New York, we have people from California, we have people from South Dakota. And what I heard is something I've heard at every job I've had in social services, right? We are all struggling with client engagement. We are struggling with getting people to understand the resources that they are eligible for. And I think the deeper thing that I always hear is the understanding that they deserve the services that are being provided. Like, that self-fulfilling prophecy. Do I even deserve what you are saying that what I'm eligible for? So that's kind of what our conversation is going to be today. Is like, how can we partner with the people that can, provide that education and the resources, but also how can we encourage our clients to understand that you deserve these resources, but you got to put a little effort in to get it. We are going to move on to the next slide. All right. So why integrating community resources improves health outcomes. So, as we know, connecting patients to community resources is a core component of whole person care. And again, we're going to talk a little bit about DePaul later on, but you will hear from DePaul or see from DePaul that they are a one-stop shop. But even with them being a one-stop shop, they still understand that they're not going to be able to serve every client because not every client is going to be eligible for the services that are provided there, or they're going to need somebody else to come in and provide that specialty support. So again, connecting patients to community resources is a core component of that whole person care, not just that specialty care. And it also creates strong resource integration supports better health outcomes. It strengthens care continuity and it aligns with health center program goals. So again, it really aligns with pulling that data to be able to prove that we are doing the jobs that we're doing right now. And stable housing also improves health outcomes. That's a big one. And I remember working with DePaul, and I remember sending clients over there. And the client told me, Miss, I am not worried about this health plan. I am not worried about this medication regimen if I do not have anywhere to live. That is my primary focus right now. So stable housing allows somebody to just breathe and, take care of those other areas that need to be taken care of. And it also reduces emergency room visits and hospitalizations. Because again, we're building on somebody's self-esteem and letting them know, like, hey, you don't have to wait until you go to crisis for you to come in and seek services. Let's focus more on prevention instead of the reactive care. And it also supports aging in place. And that's again what DePaul's model will talk a little bit about later is how can we keep people in the places they are in their neighborhoods and their communities without having them uproot. And again, I am not a medical provider whatsoever. I am a housing provider. I'm a case manager by heart. And then I recently got into HIV about 5 years ago, right? But the biggest thing that I learned is when I had to uproot somebody out of their community and help them rebuild their support system, that could be a lot harder instead of me just getting you all the services you need in your place. But let's be real, my funding only supports X, Y, and Z. So I need to partner with the other people to find A, B, and C. And it also strengthens neighborhood stability. So, health centers as community anchors. And I'm so happy to hear that we have so many health centers on this call because you serve as trusted access points for homeless individuals or people who are unstably housed. So, again, this is not a webinar necessarily dedicated to homeless individuals. However, we do see quite a few homeless individuals on this call, which is why that we are on in our agencies, which is why we need to make sure that we have those community partnerships to help them because you guys are the anchors and may be the only people that they will actually reach out to. And health centers identify patients' needs and partner with community organizations to address those non-medical factors like housing, transportation, food access, and benefits that enable self-sufficiency. And if you think about just even in the school system, I used to be a teacher. And I remember asking, like, why aren't you active in the classroom? I would have kids that would come in and take naps during the school day. Well, because the neighborhood was chaotic, the home was chaotic, or they might not have had any food in the home. And that could be for a variety of reasons. Poverty is real. It might not be anything to do with bad parenting, but you all help identify those needs and can get them linked to the right places. And health centers' public presence and visibility makes them well positioned to develop and lead cross-sector partnerships that maximize community health management and improve outcomes. So again, you guys are the center of everything. So, some of the questions we can ask, and this is big, and we'll go into this on a different slide, like what are the different funding mechanisms in your community? But whenever I'm doing any type of community mapping or whenever I'm coming into any type of community, right, I'm coming in to figure out what is already in existence in my community before I start reinventing the wheel. So, what do we currently already have within our organization? And if we do not have those things in the organization, such as housing funding, what is in our local community? What is at the city level? What is at the state level? What are the banks doing? What are the child welfare agencies doing? Like what is already in the community? So that's one question to ask. Then we also want to ask who are the organizations using funding or how are the organizations using funding to create programs and provide services? So what exactly are you doing? Because I know that we know that we love to braid and blend funding, right? But I need to make sure that I am staying in my designated lanes when I'm blending and braiding that type of funding to make sure that I'm not, double dipping. So what exactly are organizations using to fund, to create those programs and provide services? And which partner organizations provide programming and services that meet the needs of your patients? Again, I am a housing case manager. I am not a nurse. My job is not to become a nurse. My job is to learn who the nurses are in my community and partner with them to provide what I cannot provide. So that is the goal. We are not teaching you how to become a housing provider unless that's what you want to do. Reach out later if that's what you want to do. But the goal is to figure out what agencies are providing the programming that your client needs and the services that your client needs instead of you trying to reinvent the wheel. And how are patients informed about and connected to available community-based programs and services? And I think that goes back into what Mr. Randy was saying earlier. We have clients who might know the basics, but you might not know the in-depth. So how are we informing clients about what available resources are in their community? So I would love to know a little bit about where you are, right? And tell us, anybody, what resource gaps affects your patients most? And you can raise your hand, you can put it in the chat, whichever one makes you feel comfortable. And again, that question was, what resource gaps affects your patients most? And I could share just out here in Biloxi. I heard it earlier. We're in, even though it's considered a city, this is a very rural area, in my opinion, coming from big cities. So transportation is most definitely a big one. Then also knowing where I can send clients. So those are some of my biggest challenges. So it required me to do a lot of work knowing where I'm coming from or knowing the agency. So we can move on to the next slide. But again, if you want to answer that question, please put it in the chat and I'll make sure that we address it later on. So steps to building cross-sector partnerships. We want to map local housing resources. We want to identify shared populations and goals. We want to establish referral pathways. We want to develop communication protocols. And we want to track outcomes and continuously improve. And the big one is, making sure that we are tracking, closing those loops. When was the person referred? What is the status of the referral? And how did it end up? So we can make sure that we provide that data to show the impact that you all are having. So again, identifying opportunities for partnerships. So health centers do not need to address patients' barriers to non-medical factors alone. Building relationships with community-based organizations and service providers can expand resources available to patients. And some of those potential partners include local continuum of care, COC organizations, and homeless response systems. So if you are not a part of your COC, I encourage you to become part of it. And you can do that through a variety of ways. You can go to the meetings, you can try to be a voting member. But if you would like more information on that, just reach out to me. My email, I'll put my email in the chat later on. But we really encourage everybody to get connected to their local continuum of care because they have funding resources that we might not have. Also, our public housing authorities, they might have units that they need to turn over. You never know what type of partnership can be done between the health centers and the PHAs. We encourage you to do that as well. Also, HUD-funded supportive housing providers. So again, continuum of care and emergency solutions grants for emergency shelters, transitional housing, rapid rehousing, permanent supportive housing programs, whatever it is. We also encourage you to do partner with affordable housing developers, as well as homeless service providers and shelters. I will stay with a list of shelters next to me, especially when I'm working in New Orleans to make sure I can serve my populations. And then housing navigation agencies. Again, you heard Marissa say earlier that she is the housing navigator of her agency. So it is her job to go out into the community and find both private and public landlords that are willing to rent to her clients. And I cannot stress this enough, state and local government housing departments and health departments. So when we talk about DePaul, I was working at the City of New Orleans Health Department when I started working with them, and I was a linkage to care coordinator. And they did such a great job with serving their clients that they were one of my top referral sites. And I had 9 hospital systems that I referred to. And I would say they were in the top 2 or 3. And I tossed them some very tough clients and some really easier ones. But they did such a great job that it was a two-way partnership. I was calling them to service the clients that were calling the health department. And when you think about when somebody's calling the health department, it's typically because somebody's putting a complaint in or they're looking for services and they have exhausted all options. So they were one of my go-tos. So I encourage you to partner with your state and local health departments, especially the specialty clinics, because I was in the HIV department, so the Ryan White program, as well as our faith-based and community-based organizations providing rental assistance. So I would love it if you can put in the chat any other people or potential partners that are missing from this list, because I see a couple of them. And again, coming from, a case management background, I always tell people if you have any clients who have child welfare involvement, we need to be partnered with the child welfare agency, because they have resources that you won't have. And their whole job is to, get the family reunified if that is on the case plan. So make sure that we are, partnering with the child welfare agencies. Are we partnering with DOJ, partnering with the reentry workers? Workforce development, whoever it is. There are so many partnerships that are not on this list. This is specific really to housing, but we encourage you to reach out to them as well. So again, our key areas to map include food assistance, our basic needs, food assistance, utility assistance, and emergency financial supports. So again, a lot of my clients from the health department would always call about emergency financial assistance or housing assistance, even though it's the HIV line. So some people might be coming to me for testing or to be linked to medical care, but a lot of them might actually be calling for housing assistance, food assistance, or financial assistance. In transportation, we have public transit programs. We know a lot of programs love to give out bus passes and non-emergency medical transportation. Our benefits and employment folks, so our Medicaid enrollment assistance, our workforce development programs, and our health and behavioral health program. So our specialty providers. DePaul isn't able to serve everybody at their community, at their FQHC. They will have to refer out. So we also want to make sure that we have those specialty providers as well as our behavioral health agencies. So again, using DePaul for an example, they have on-site behavioral health, but not everybody is going to be appropriate for that program. So we want to make sure that we have those therapists that are aligned with our clientele. Available at any moment, as well as substance use treatment programs. So even though I said all of this, we know that all of this depends on your area. It depends on the funding available. It depends on the client's willingness. So this is just a list of areas to map, but there are so many other factors that we need to take into consideration when we're talking about service mapping in your areas. So some of this is what we're calling building effective referral pathways, right? So there's a 5-step process. We want to establish partner relationships. So we want to meet with these partners regularly. We want to understand services and eligibility criteria. And we also want to identify points of contact because we all know this field turns over. So having just one contact at an agency is probably not the most appropriate thing. We need multiple contacts. We also need to understand that the services and eligibility criteria. Again, you might I remember I had this client, I was working at one of the jails, and the client, you had to have HIV. To receive my services. And because I worked with him so well, got him housing and everything, well, he went back to jail. And the client went in and told, hey, I know somebody you can reach out to when you get out, blah, blah, blah. He left the part about HIV out, right? So I had multiple people calling me trying to receive housing, but I had to get I would say creative with how I asked the question, do you have HIV? So do you have any chronic diseases or anything that I should be aware of? And this now, have to do an eligibility screening or whatever it is. So the big thing was making sure that I had to tell that client, hey, unless this person is living with HIV, I would not be able to serve them. Thank you so much for thinking about me. We can refer him to somebody else, but making sure that you understand and my service providers understand that this person has to have X, Y, and Z to be able to be seen. If not, we can refer you somewhere else. So again, just making sure that we understand the client we are serving and the best points of contact and meeting regularly. And that can be once a month, that can be every 2 weeks, whatever you decide. And we also want to develop a clear referral process. So define where referrals should occur. So is that through a tracking system? Is that through a fax? Is that through email? Whatever it is for your agency. We also want to standardize referral forms and workflows. I'm not trying to fill out a 20-page referral form to you, like whatsoever. We want to make this simple, right? But we, at the same time, we want to gather as much data as possible and also create that warm handoff procedure, right? Just dropping somebody off or saying, hey, show up at this time and you're not there. The client might not show up because they might be afraid you might be the only person they trust. So how can we create a warm handoff procedure? And we also want to promote two-way communication. So we want to confirm the referral receipt. We want to share status updates when appropriate, and we want to troubleshoot barriers collaboratively. And I think we all have, dealt with that before. Um, you know, you never know what might happen in somebody's life. So how can we help somebody troubleshoot those barriers? Some of the barriers might be mental. So how can we help somebody walk through their anxiety to get them to show up? That might take the both of us, right? That might not just me, that might be both of us. And we also want to track outcomes. And this is very key to make sure that we are telling the story of your agency. The number of referrals you made, the number of completion or the referral completion rates, connections to housing and services. And I encourage you to list out everything you referred them to when you're putting your numbers in the system, as well as patient engagement outcomes. And then we also want to continuously improve. So I am big on feedback. I want to make sure that I am meeting the needs of your clientele as well as the service provider. So we want to, again, meet regularly. We want to review challenges and successes to see how we handled it and where we can improve. And we want to adjust workflows as needed. So before we move into this next portion, I would love to hear a little bit from you all if you feel comfortable. You can put it in the chat. But you tell us which step does your organization need to strengthen to strengthen your outreach for community partners? I'll give it about 1 minute. You can always raise your hand. You can put it in the chat, whichever one you feel comfortable with. Okay, I have something in the chat. Let's see, what do we have? Tracking outcomes. Yes, that's always been a difficult one, especially if you are in direct service. We know that can be a little hard. Tracking outcomes, see, Tavin said the same thing. Outcomes of completion and whether connections were made. Yes, very key. Thank you both for sharing. Promoting two-way communication. Yes. Yes. I've most definitely had to deal with that before where it's like it feels like I'm the only one doing the work. Like how are we serving one another? And then we had to really figure out like, okay, what's the best point of contact? And you might not be my best point of contact. I might need to find somebody else. Thank you so much. All right. Again, keep putting stuff in the chat if you feel comfortable. I'm going to move forward. So You all get to see. So again, we had a little bit of a pivot. We love to say the art of the pivot, and anybody who's been in direct service knows you might have something come up, and they are a large community health center in New Orleans. They had something come up, but I still wanted to put their faces and their email addresses in case you need to reach out to them. So our speakers today were supposed to be DePaul Community Health Center's Mrs. Patrice Paisley and Mr. Eric Stovall. Now, for Mrs. Patrice, she is the community health navigator supervisor. So pretty much the CHW, the community health navigators, she oversees that department. And they do so many things in the city of New Orleans. So I'm not sure if anybody has been to New Orleans, but it is more than just a party city, right? It is a city full of culture, full of history, full of community, and they are one of the biggest community providers out there. They are in the streets doing with their mobile units, doing whatever they need, and she runs this one right here. So I'm very proud to say that I've worked with both her and Mr. Eric Stovall, who is the infectious disease operations manager. So that's a fancy title to say that he ran the Ryan White program. So how we would do it is I would get a call on my phone. And again, 50% of my clients were either trying to be linked to testing or linked to medical care, or they were looking for emergency financial assistance or housing assistance, and they were a person with HIV. So my job would be to call Eric and say, hey, I have a client that either needs to be tested, a client that is already has HIV and needs services, needs medical care, needs whatever it is. Can you get this person linked? And I would say between 24 to 48 hours, that client had a doctor's appointment. Whether it was for ART, whether it's for testing, whatever it was, they were able to get that person in right away. But when I was doing my assessment, I'm not just asking, are you a person with HIV? Are you this and that, blah, blah, blah. I'm asking all these different questions so I can give them the entire rundown when I call them. And then that's when we would see like, hey, they might need a little bit more assistance. So say it's somebody who's not living with HIV, who just needed to get some testing done. But because they were nervous about the test, they just need some more information on HIV and HIV prevention. Then we would bring in Patrice's team to, do the community health education and just talk about the resources in the area. So these were two people that I refer to all the time. Again, take their information down. If you have any clients transferring over to any areas, and I will say I've lived in so many different cities and I have transferred clients to multiple cities before. So you never know where a client might end up. So let's go into their conversation. So DePaul Community Health Centers. They currently have 11 centers, health center locations, and two mobile health units serving the greater New Orleans region. And they serve approximately 50,000 unique patients annually, and 13,000 of those patients are children. And they also provide school-based services at more than 20 schools, and 97% of the patients meet the federal low-income guidelines. So that's just a little bit about them. So before we talk about why they created the health, housing, and community program, I would say that, again, New Orleans is so much more than what the reputation is, right? There's so much history, there's color, there's just everything going on in that city, but there's also a lot of poverty. And so to make sure that they were meeting the needs of their clients, that's why they created the Health and Housing Community program. And this was created to address the connection between housing, healthcare access, and overall health outcomes in the Central City neighborhood of New Orleans. And they currently have 192 affordable apartments. 100 of those units are for families, and 92 are for seniors. And it is income restricted, up to 60% of the AMI, the area median income. They're also a Fitwel certified healthy building. So why was it created? Again, to improve health outcomes by combining affordable housing with convenient health access, because they are actually located on the first floor of the unit or the development. And they address housing instability, transportation challenges, insufficient access to food, and limited healthcare access. And they do this by partnering with medical or offering medical, behavioral health, pharmacy, and Medicaid enrollment on sites. And again, the whole goal is to help somebody age in place or just live in place without us doing all those system disruptions. So again, this is just a little bit, this is their team, one of the mobile health unit teams, and they are always at some sort of community event. But within their role in the H3C program, again, they provide the on-site health center, the primary care, pediatrics, and the behavioral health, but they're expected to serve between 5,500 and 10,000 patients annually. So just think, 192 units, and I'm going to serve that many patients. Now, again, it's not just 192 families, just coming downstairs and saying, I'm going to come down here 10,000 times. No, that's not what we're saying. We're saying it is open to the community in the area, not just the clients that are living in the building. But again, having that presence in the Central City area in New Orleans is very key. So some of their key partners, again, this was not just something that DePaul did on their own. They had to partner out with people because again, they are a health center. They are not a housing development partner. Or so what did they do? They had to partner with somebody who was. So they had the Gulf Coast Housing Partnership who took care of the housing development, and DePaul took care of the services. Then the community health navigators, they took care of the care navigation. The Ryan White team, they take care of HIV care coordination. And again, this is not an HIV specific building, but some of their clients are living with HIV. Then their Bill Rev programs provide supportive services. And they also have a partnership with Aetna and CVS for funding support and pharmacy support. So a little bit about their Community Health Navigator program, especially in the H3C project. It brings affordable housing, health services all together in one local area. And the CHNs are the operational bridge between healthcare, housing, and social services. So again, they are your first people. So we say community health navigators. They are also considered community health workers, where we know that they are the some of the most impactful people because they know the resources in the area, they know the needs of the community. So they are typically the first people that somebody sees and the go-to people. It used to be us case managers, but now they've taken our places. And I love that for them. So they connect patients to care and patients and residents to care and resources. They provide the health education and the navigation. I think that goes back into what Randy was saying earlier, right? It's not just about the resources that we're providing. Like, do you know exactly what you were diagnosed with? Do you know the medications that you are taking? I remember going to the doctor the other day and with all my medications, explain every last one of these. Now, it took a lot for me to get that level of assertiveness to be able to ask that question. But that's what the health navigators do. They encourage you to ask those questions so you know exactly what's going on with your medical care. They also help support chronic disease management, and they are a bridge between health literacy and trust gaps. Because again, you think about New Orleans, think about the history of New Orleans and Louisiana. Of course, naturally, there is going to be some mistrust and trust gaps within the systems out there. So we want to make sure that we have people that can help bridge that gap to say, hey, I understand exactly what you're saying, but this is what is going on. So how can we work together to create a good plan of action for you? So again, they also, with them having the on-site presence in the housing development, they are able to provide the home visits, wellness checks, assessments, and health screenings. And how this looks, right? You'll have somebody who schedules an appointment with somebody and they don't show up. So guess what? The benefit of living in this development is I can walk right upstairs and knock on your door. And I have done that so many different times in housing, right? Just working in housing and permanent supportive housing, we know that aging in place is something major, especially with somebody who has behavioral health issues or anything like that. We don't want you isolated. And sometimes that's what happens. So the CHNs actually act as the person to go knock on their door. Sometimes that's what you need is the person to go knock on their door and bring them downstairs, to go to their medical clinics or go to their assessments, to just be in community. And I've seen that happen with them a few times. They also provide assistance with the benefits enrollment. And a key thing is transportation out here. And between Louisiana, Mississippi, Alabama, we all refer clients everywhere. So transportation is a major one. And they also provide coordination with DePaul clinicians. And with this case, they also do referrals and linkages to the Ryan White program. So again, DePaul has multiple programs. But for this case study, we wanted to talk about how they provide referrals over to the Ryan White program within their own agency. So CHNs in the I'm sorry, in the Ryan White HIV/AIDS program community at DePaul. So they provide comprehensive, person-focused HIV care. And the goal is to support individuals with HIV through a coordinated multidisciplinary care model. So it's not just you just seeing one doctor there or one case manager there. We are going to serve you as well as possible, but that means I need to either be partnered within my own organization. And just think about it. How many times we work in agencies where we are siloed, where the behavioral health folks stay with the behavioral health folks, the Ryan White folks stay with the Ryan White folks, the healthy eating, I'm just naming something, healthy literacy places, right? They stay with their folks. Our goal is to make sure that we are referring out to everybody. So we have to break out of our silos to do that. And the program focuses on improving health outcomes, reducing barriers to care, and helping patients achieve viral suppression and long-term wellness. And that is key because I want to stress that receiving a diagnosis of HIV, no matter your age, no matter your gender, no matter what, can be a very traumatic situation. Anybody who has diagnosed anybody with HIV can attest to that. You never know what you're going to get. So one of the things that we have to do at that moment, at first diagnosis, is love on you a little bit and let you know that you are worthy of the services that are going to be provided to you. But how do I do that? By building that relationship and coming to you and your agency. And that's what the CHNs and the Ryan White program does. So even though the Ryan White program is housed in another building, if somebody is not showing up for their appointments, you can guarantee that the case manager and the program director will go out to that unit to go see that client to figure out how can we best serve you? Is that us coming over here to make sure that we serve you better? So effective integration, how the CHNs and the Ryan White program support the H3C clients. We streamline referrals from the CHNs and on-site clinicians. So again, the CHNs are the ones that are doing the assessments. They are taking down as much information. So when they go to the case managers, when they go to the clinicians, when they go to the nurse practitioners, they're saying, hey, this is exactly what this is what this client disclosed. And let's set up a warm handoff so I can actually, get this client to feel welcomed in the area. So what they're doing is they're streamlining those referrals and they're giving the clinicians as much information as possible before that person walks in. So we don't have to keep re-traumatizing the client by telling the same story. And again, we are doing that warm handoff. So I have literally seen whoever is the CHN or the nurse at the time doing the intake, we will all walk back to that clinician and we're all sitting in that room unless that client says, okay, it's too many of y'all, I'm good, right? But we are making sure that we are doing those first initial appointments with them. And they are also providing the on-site or nearby access to HIV care. Even though I might refer somebody to DePaul, they might not fit at DePaul. They might prefer Tulane. They might prefer Crescent Care, whatever it is. It all depends on their stigma as well. If somebody is living with stigma related to HIV, the last thing I'm going to do is refer them over to one of our HIV clinics that is known for HIV. I'm going to do something a little bit more discreet. So that's why DePaul was always my go-to. And we would say the integrative behavioral health and pharmacy services. So after a diagnosis like that, and it doesn't have to just be HIV, it can be whatever you're diagnosed with. Sometimes we need some help, just getting back to baseline because it could be very traumatic. So we are making sure that we are integrating that behavioral health and those pharmacy services. And again, we are reducing stigma by embedding services within a community health setting. You would never know what somebody is going through in that agency or in that housing development unless that client discloses, because of course we can't, but unless that client discloses. And since it is a building not designated to any specific condition, just your area and median income, we are able to reduce that stigma and have real conversations. So some of the community partners that they work with is No AIDS Task Force and Crescent Care, which is now known as Crescent Care. And that is one of the longest standing HIV providers in New Orleans. So they do the prevention, the testing, and the wraparound services. They do a lot of different groups. They have food pantry. They have a lot of services. But again, if you are a person living with stigma, we try to do as much on the outside instead of you actually going in there. But they are pretty great at what they do. And also, they also partner with the Louisiana Office of Public Health for surveillance, linkage, and statewide coordination. So that's big. Use your health departments, use them for their resources and to gather that data. So again, the City of New Orleans Health Department, that was my job to provide the linkage and the citywide coordination. So my job was to know all of the resources, not just the Ryan White specific resources in our area. I had to know everything because I never know who is going to be on that call, especially just using a family who is involved in the child welfare agency. If I get that call, I need to make sure that I'm putting you in a place that could not possibly damage your case, that will mess up your reunification track, whatever it is. So I'm making sure that I know the resources in that area. So partner with your health departments because you never know what knowledge those communities, those linkage coordinators might bring. They also partner with Brotherhood Inc., and they provide the housing, food, community outreach, and support for high-risk populations, women with a vision, that is the housing, engagement, and social supports. And this is for women who have exited the justice system. And so there are Louisiana, specifically New Orleans, they are doing some major work in reentry. So we have the first 72 plus, we have Women with a Vision, which is an extension of them, and we also have Voices of the Experience, where you have people who have done long-term sentences. I mean, anywhere from 50 to 60 years that have gotten out and said, hey, let's advocate for the people who are stuck doing life sentences for crimes that they should not have received life sentences for. So because they all did that 20 plus years ago, they created Women with a Vision. They created the first 72 plus, and they are able to really help people address the needs, but they are also partnered with DePaul for the medical. They're also partner with Tulane, with UMC, whoever it is. They are partnering with those medical providers to be able to provide that support. And again, the local hospitals, infectious disease specialists, to provide the advanced care and specialty referrals and community-based organizations. Because again, there's only so many things that we can do, and nothing is worse than you want to support this family, you want to be able to do this, but you can't because you are running out of resources. You are running out of funding. So when I can't find funding in my agency, I have to try to find the agencies outside. And I would say, even though my job is to try to stay in the New Orleans, Biloxi area. Sometimes you might have to find outside. Like in one of the last webinars I was on, we were talking about the city or the state of Pennsylvania. And it's just crazy how many of us have referred out to counties that are 4 hours away because that's where the resources are. So unfortunately, sometimes you have to know the resources in other areas or at least know the questions to ask to find those resources. So, what made this partnership so successful? Going back to the H3C model, they had a shared mission. They aligned commitment to improve resident health and well-being. So that's all departments from the real estate developers down to the pharmaceutical reps, down to the case management agencies. They made sure that they had aligned commitment to improve resident health and well-being. They also had leadership engagement. So a lot of things aren't going to move unless we have our leaders, and we know the leaders are looking for that data. So executive leaders championed the vision. They built trust and removed the barriers. They had early partnership development. DePaul was involved during the planning, not after development was completed. So they were sitting at that table saying, hey, no, you might want to consider this. You might want to consider this when you're doing your building, whatever it is. They were sitting there at that table. They also have very strong relationships. So ongoing collaboration with the developers fostered trust and problem solving. And anybody who does housing work on here knows that when a landlord can call you to solve an issue, you're going to smooth some stuff over because you're going to have some issues. I've received a lot of calls the course of my career, but them knowing that they can call me and that I have finances to take care of any of the issues that might come about, that helped us a lot. And then we also had clear roles and accountability. So defined responsibilities supported efficient implementation and continuous communication. So regular engagement kept partners aligned and responsive. And the focus was on housing as healthcare. So we recognize that the connection between housing stability and health outcomes is significant. Again, going back to what my client told me, that totally changed my mind. Miss, I am not worried about this pill or this regimen until I have somewhere to live. How can I have a medication that requires refrigeration with no refrigerator? So this program was created because the focus is on housing as healthcare. I can address those other issues. Let me get you stable first. Let me get you in a house first. Let me get you rested first. Then I can move around to the other areas. So the impacts that this had on the Ryan White program. One of the key outcomes was the retention in care. And this was a 15.3% improvement. Now, DePaul already has pretty high numbers of retention in care, but we see that because of what they were able to do, we saw the 15.3% improvement. We also saw a viral suppression increase. Oh my God, 85.7% increase in those numbers. Wow. And this is from our chronically homeless population. The missed appointments, there was a reduction of 53.8 or a 54% reduction in missed appointments. And then we also saw the ER reduction. So the emergency room utilization went down to a 38.5% reduction. And primary care engagement. Again, our job is to teach clients how to get out of crisis, and that's a whole nother job in itself. But what we did is we saw that the primary care engagement went up 30.6% when people had it had not only a safe environment, but also had a team of folks, including those community health navigators, rallying around them to help them get the services they need. So looking ahead, we would love to see future health or other health centers model for have this be a model for future health and housing developments, right? How can we bring in the real estate developers? How can we bring in the health providers? How can we bring in the social service providers to create these agencies or these developments that really focus on housing as healthcare? We also want to see a potential expansion of the community health navigator services in the community. Again, living in New Orleans, you see DePaul everywhere. We would love to see how we can get a little bit more strategic with that. And I would say New Orleans has a different way of doing everything. And one of our old campaigns was called the Bounce to Zero campaign. And Big Frida, one of the local bounce artists who is pretty well known, she is actually our brand ambassador. And what's that saying is you need to bounce to zero, bounce the HIV rate down to zero, right? So using the community health workers, using the local celebrities to make sure that we expand the services. And then we also want to strengthen community partnerships and then do the more the long-term investment in neighborhood health. So the key closing takeaways is H3C demonstrates the power of integrating health care, housing, and community support. And DePaul anchors the model with accessible, high-quality care. The CHN strengthen resident engagement and connect individuals to essential programs, including Ryan White services. And there are strong partnerships across New Orleans that enhance impact and sustainability. And this is a scalable model for healthier, more resilient communities. So we would like to thank DePaul, even though they weren't able to be here for this one. We would like to thank them for this one. And actually, since they aren't here, we are going to end our webinar a little bit earlier, unless we want to open this up to you all. So before I actually open this up, I would love to stop sharing and just ask you about your services. Tell us about your agency and what you are doing. And do you see yourself in DePaul? Like, what are you doing in your area? So, because again, you guys doing a knowledge share is a lot more impactful than me just up here speaking. So, I would love if somebody can unmute and tell us, like, what did you think about DePaul? Do you have something going on in your area? Tell us. If not, we can end early.
I would say for DP Health, we have similar services like DePaul. We do have community service, healthcare navigators that go out to community. They have an RV that they go in and they go to the washes. They provide hygiene bags. They provide whatever the client may need. For us as well, we like for DP Health, for the housing department, we also work closely with the medical case managers, and we do provide vouchers for clothing, for shoes, so we don't leave them not heard, since we do have a lot of clients that are homeless. And we do try to help them find alternatives, if it's rehousing programs, if it's shelters or whatever they may need, then we can assist them. We always try to get them just on the fly, because if they leave us, then there's no way of communicating with them, because they're always losing a phone or not, or whatever the case may be, you're stealing a phone or whatever. Um, but they always find their way back, and then they always, you know, once they disappear for a period of time, they always say, I think I'm ready. I think I'm ready to start my steps, and then after the way, we support them in every way we can, and just to let them know that they're not alone.
Thank you so much, Marissa. And I've had the pleasure of seeing DAP in action. And like she said, my gosh, they have so many different resources there to really wrap around that client. And so thank you so much for sharing that. I would love, Miss Anita, I remember you said that you are from South Dakota, and I would love to hear more if you are willing to share just about how it looks in South Dakota and how are you working with the rural population with community partnerships. And I hate to put you on the spot, so please forgive me if I did. And I did. So you all, I thank you all so much. We are going to launch the poll right now. Again, I want your feedback on this one. What did you think about it? Just let us know so we can improve future sessions. But thank you so much, Andrea. We are able to launch the poll. And I hope you all have a great day. You are welcome to sign off once you are done with your poll.
Bye, Becky. I'll see
Bye.
you. Bye.
Thank you. Thank you all so, so much.